Hello everyone, I welcome you all in this webinar, expert series webinar by Asian Pain Academy. Today, our speaker is a very renowned neurologist of our city, Dr. Ashish Datta, and he is actually DM Neurology, and he will talk on approach to headache, and headache is our very commonly we see in the pain clinics. So I welcome Dr. Ashish Datta, and we are grateful that he has given his consent that he will present this topic in this webinar. So Dr. Datta, you can start.
Thank you, Chinmoy. I think I'm audible, Chinmoy?
Yes.
Yeah. So Chinmoy is my good friend, and we were colleagues for a long time. So maybe 7-8 years back. So when Chinmoy told me, so naturally there was no other way always to say yes. So good evening, everybody. First of all, I'm thankful to Dr. Chinmoy, members of Asian Pain Academy, and colleagues present here, that in spite of busy schedule and maybe a time when to rest at home, they are still here to enjoy the session. So I will first share my slide. You have it. In my
yes, clear listening.
Yeah. Okay. So in the next maybe half an hour, so it would be rather an interactive session. That would be better rather than to be I'm saying and everybody listening like that. But initial half an hour, so would be something I will present a model of how a neurologist actually looks into different headache disorders. And then thereafter, I will present a series of presentations in a clinical oriented manner. So that would be nice to hear rather than to be a didactic lecture going on like this. So it would be, I think you will not feel bored over the next 30 minutes because the presentations I have made like that way. So no need to swallow all the information, it's available. Rather, we should learn this session in a way that we will all enjoy. It's like a learning, like a way of 3 idiots. So we will learn in the next half an hour by way of like this, by sharing our knowledge. So first of all, what is headache? A very common and pertinent question. In simple terms, it's pain anywhere in the region of head, neck, and maybe in the upper face. So that is a headache, that is common entity. But always to remember, headache is just a symptom, like a fever. If you have a fever, it could be anything starting from a viral fever to UTI to meningitis. Similarly, headache could be an innocuous disease too, can be a manifestation of a devastating disease also. So it's just a symptom of different conditions. There is thankfully our brain is insensitive to pain. Otherwise, we could have much more headache, but the brain itself is insensitive. But headache occurs because of involvement of pain-sensitive structures in the brain, which are mainly our dural venous sinuses, dura mater, and the dural blood vessels, meninges, pile blood vessels. These are the areas which are pain-sensitive, and that leads to, because of stretching or involvement of those areas, we get pain. So we get pain whenever there are meningitis, whenever there is something leaking into CSF, and all those because of stretching and involvement of meningeal structures. Now, how headache is common? If we look into almost 3/4 of us, all adults, will have one headache per year. So you can see how it is common. Out of here, if you are 20 people, so maybe out of these 15 will have one headache per year. And of these, the 5 to 10% should be severe enough to have the physician's help. But there is a good thing is that there are many patients comes to the emergency will have a secondary cause of headache. Now I will come gradually what are those secondary causes. So headache in terms is a very common, but those patients attending in accident and emergency, out of those only the 10% will have a secondary cause. We look at, this is a fantastic survey that was done by ICMR as well as PHF, I means Public Health Foundations of India in the year 2019. So you can see itself in India, we have 488 million people with headache. So the number speaks for itself, how common it is. And among them, the migraine and tension type headache, these are the predominantly two headache commonly happens. Now, how we will look or how we will approach whenever a patient is having headache. This is classically that we have been taught from MBBS, that we look from history, then go for a clinical examinations, and then few investigations to find out. I will not elaborate this, but little amount I will put my cracks on that age is important for few headache disorders. Like for an adult, the common primary headache disorders are much more common. And for elderly, the secondary headache is a much more common than that of the adult populations. So any patients in elderly presenting with a headache, new onset, you have to then think of, yes, whether we are dealing with a secondary headache or not. Similarly, there are few headache which are basically common in male populations and few are in female populations. I will gradually come into those. So similarly, the second most important factor is whether it is a holocranial or a hemicranial. So hemicranial headache is the most common presentations is a migraine headache. And when it is a holocranial headache, dull aching, it can be a tension type headache. If it is for a particular area like temporal area, so it could be a temporal arteritis also, particularly if it is in an elderly female. And if we look into it's for a particular periorbital pain or like those, it could be some other features or other disease like even cluster headache also. So site is important also where the headache first starts. Now, many of the persons you will see that they are a little confused to say where it starts. I have my headache on both the sides, it starts here, then it occipital, like those. So, but little bit digging out where it first starts usually gives a site that is the first. Like the headache that starts in the occipital area, maybe that it could be a cervicogenic headache also. So the headache site gives some importance also. Then what character of the pain? The throbbing pain is a more common with a migraine headache, dull aching with a tension type headache, self-shooting pain, it can happen with cluster headache. So itself, the nature of the headache characteristics will speak something about the underlying diagnosis. Next, how it started. Like for a migraine, it should be a chronic disease going on, episodic nature. For a subarachnoid hemorrhage headache, it should be very hyperacute, thunderclap-like presentations. Onset is also important. Durations, for how long it is happening, each episodes for how long it is running, like those. And then it is episodic or a constant disease, like constant is a more common with a tension type headache, episodic is more common with a migraine headache. Then we have to look for any associated phenomena. Now, this for associated phenomena, if we are looking into primary headache, then whether the person is having photophobia, phonophobia, osmophobia, exertion or physical activity, whether that increases headache or not, these are important factors. What are the precipitating factor like those? And for other secondary headaches, so where there is any other clinical findings, any focal neurodeficits, any nasal congestions, any redness of eye. So you just look into, along with the headache, what are the other symptoms that can be of a importance. As I talked, you have to look for a precipitating factor and relieving factors, particularly for migraine. As we all know, they're going for a scorching sunshines, exposure to heat, and in empty stomachs, travel, smell, perfumes, sometimes are the precipitating factor. And the sleep is itself a relieving factor. You have to look for comorbidities because of the few situations, the comorbidities also dictates the underlying conditions also. Like if the person is an obese, hypothyroid, and the person is having a headache, some visual obscurations. So might be you are dealing with a idiopathic intracranial hypertension, which is more common with the obese population. So associated comorbidities and family history, these are all important factors. In essential, neurologists divide headache into two types. Very easy. One is a primary headache, where there is no underlying cause or something life-threatening causes. And one is a secondary causes, where secondary headache, where the headache is because of an underlying disorders. So naturally, here you have to find out the underlying disorders and treat the underlying disorders. So we will first deal with primary, followed by secondary. So for any patients that comes with a headache, we look for headache alarms or red flags. This is very important. From this point, the next slide would be very important, because this would be a very screening things that you can do it in your OP clinics or OPD clinics, maybe in emergency also when the patient comes in with a headache. So you just look for whether there are some red flags or alarming signs. If there is no alarming signs, then possibly you are dealing with a primary headache. And if there is an alarming signs, then look for whether there is anything for secondary headache. Now, what are these alarms or the red flags? Headache that first onset is age beyond 50 years. So the person came to you for a consultation who had developed a recent onset headache and he is more than 50 years old. So naturally, you have to think of secondary headaches in these situations. Primary headache can happen beyond the age of 50, but for the first time, if it is more than 50 years, you have to look for a secondary headache. Then any headache that is in explosive onset or maximum severity at the onset, then you have to look for secondary headache. I'm giving you an example, like explosive onset, severe headache is a subarachnoid hemorrhage. So you look that whenever a person comes with a worst ever headache in life, you have to look for a naturally whether subarachnoid hemorrhage is there or not. If there is a no similar headache in the past, so this is the first onset, severe headache, if age is more than 50. If associated, there is seizure or a convulsion or any visual disturbances or changes in mentation, means the person became drowsy, irritable, not following commands properly. So you look, possibly you are dealing with a secondary one. Then if there is a concomitant infections, if the person is having, if it is a pregnancy or a postpartum state, so a patient who is pregnant presented with a first time headache or a postpartum pattern, I will come with examples of all these, so no need to mock up. So at the end, we will have all the examples. And if the person is on immunosuppressions, our medication history is also important. Suppose the patient is on blood thinner, had a trivial head trauma, presented with a headache, little drowsiness, so maybe a subdural hematoma can be responsible. So that gives a clue that even with a head trauma, trivial, but who is on a blood thinner could land up with a something called a subdural hemorrhage. Next, you divide presentations into two parts. One, those patients usually present in the OPD. Now you can understand which are a benign disease or a primary headache disorders like a migraine, tension type headache, or cluster headache. But clusters can sometimes come into emergency also. Migraine acute can come sometimes into emergency. But these are predominantly patients that attend the OPDs. They can attend the OPD. So these are patients, those present in the OPD. And there are patients who present in the accident and emergency because of sudden severe headache. So those categorically would be different. So I will deal in two different ways. One, where they present, number one, in OPD clinic of yours, or where they have attended in accident and emergency, and you got a phone call that, yes, Dr. Chinmoy, I had a patient who presented with like this. So what should we do? Should we admit? Should we do a CT scan? Or should we say them to meet with you in OPD tomorrow, like those? So that way would be easier to understand now how we will approach headache nicely. So if we look into the primary headaches, so there are three kinds of primary headache predominantly. There are other kinds, but for us, for today's presentation, I will stick to the common one. So one is a tension type headache, second is a migraine, and third is a clusters. I told you in terms of actually their prevalence, you can think. So tension type headache is the most common, followed by migraine in our country, and then followed by a minuscule would be the cluster headache. But why I put even the clusters? Because it is very important to identify cluster, because they do not respond to other medications. So until and unless you give a very specific medications. Now, as I promised, it would be a clinical based discussions. Now let's start. So this part would be the most interesting, and this I feel to be the most important. Number one, 5 years old female that presented with history of episodic headache. So these terms, the words are very important. Please have it. Episodic headache, which are hemicranial, means in half of the head. That is pulsatile, means something that pulsate like those pain. And they were associated with nausea, feeling of vomiting, photophobia, and phonophobia. So something fear of light and fear of sound, like those. And these episodes are present for the last 5 years, but there is a recent increase in frequency, which is now almost becomes 15 to 20 days per month for last 4 months. And along with history of intake of analgesics, means any pain relieving medications, more than 20 per month for the last 3 months. So very important. This lady presented, no doubt you can understand, she is very grave situations, that though she had a episodic headache, which looks to be pulsatile, hemicranial, associated nausea, vomiting, photophobia, phonophobia. So like this, with a recent increase in headache frequency, and as the headache frequency increased, she goes on consuming much more painkillers. So that is the history. Now on clinical examinations, absolutely normal neurological examination. So she does not have anything. In headache, this is the one thing in primary headache, every neurological examinations and investigations is normal. So you have to rely on the history very meticulously where you will land up. And for secondary headache, sometimes you will get a clinical clue. That is the most important. For any secondary headache, the clinical clue is from yours, either from history or from a examination point, that you will go for a next level of investigation. Now, if I say, what is the diagnosis? You did a imaging, you wanted, no, this lady is suffering from so long, we need an imaging, whether something is there. So like those, and we needed an imaging, and imaging was normal because she was carrying already 3 imaging that has been done, and it was normal. Now, what is the diagnosis? If I say, so naturally, everybody of us will jump on to say that this is migraine, the one of the most common type of primary headache. No? Migraine is a unilateral pain, throbbing pain that are associated with photophobia, phonophobia, osmophobia. So like this, then this lady has that same thing. I'm not coming with any international headache disorder criteria of every disease, but that will make us bore. It's all available in internet. So my presentation would be clinical oriented, as we are all clinicians. So naturally, we jump onto, yes, this lady is, diagnosis is a migraine, and you prescribe the medicines. One is for acute relief and one is for prophylaxis. But are we right? If we ask ourselves, we were right to diagnose the same thing, that she had a migraine, number one, and number two, whether we are right in prescribing the medicines that we have given to her. Now, if you look into this whole history, there are a little caveats. Next, come to the same thing. If we break the history like this, from 35 years old lady who had an episodic headache for last 5 years, the diagnosis itself is a migraine without aura. You don't require an imaging. This is a very classic diagnosis of migraine without aura. But what about this thing? With recent increase in frequency to 15 to 20 headache days per month for last 4 months. Now the diagnosis changed to chronic migraine. So here comes the difference. So this lady no longer belongs to the category of migraine without order. Rather, she belongs to a category called chronic migraine. Why I am emphasizing? Because the treatment would differ. So we have to emphasize where the treatment differs. So naturally, we are a clinician. So we want that patient should be better. So we should diagnose the same thing in a different way, rather, what is the exact, and we should offer the best treatment. Now, what about the last line? This lady again had history of intake of analgesics more than 20 per month for last 3 months because of her increasing pain frequency. When you get these things, your diagnosis becomes medication overuse headache, or MOH. So now you can understand the whole history evolved in a lady who had a migraine without aura, landed up with a chronic migraine. By definition, if you have a headache days more than 15 per month for 3 months, that's qualified for chronic migraine. And because of increased painkiller, so she landed up into medication overuse headache. By definition, if you take more than 15 to 20 painkillers, more than 15 painkillers per month for consecutive 3 months, So you belongs to a category of medication overuse headache. So you can understand now this lady belongs to a category of medication overuse headache. Now look what treatment we have offered her was a medicines for acute relief of pain, and second, some prophylaxis. But we should not prescribe any painkiller to this lady because who is already medication overuse headache. So that should not be. So the treatment of medication overuse headache would be to give a short course of corticosteroid to reduce the continuous inflammations in the brain, trigeminal all systems, so that this chronic headache would go into episodic headache. So that lady from medication overuse headache will go back to the migraine without or episodic, and along with a short course of corticosteroid, we would give some prophylactic medication so that she would not again land up into chronic migraine, but we should not prescribe any painkiller medicine so that she should not be again landed up into medication overuse headache. So that is the beauty, how you look into the history, and then accordingly, because if you give a painkiller, she will never be cured. So that is very understandable that to stop all painkillers, to give a short course of steroid, and this the pain goes. He gets a honeymoon period during corticosteroids. So naturally thereafter the prophylaxis starts. We give a 7 days corticosteroid, full dose 40 milligram, followed by tapering dose over the another 7 days, as we know. So that is. So for migraine, described you the presentations that can happen is the most common presentations, but there are few presentations in migraine where we can be fooled also. So like there are a group who has a predominantly dizziness. So part of headache is a less, dizziness is a more. This is an entity called migraine associated vertigo, or MAV. So you will frequently have patients who complain, ডাক্তারবাবু আমার না মাথাটাও একটু ধরে যায়, মাথা ঘোরে, হ্যাঁ মাঝে মধ্যে, হ্যাঁ তখন ভালো লাগে না. So we all ascribed, majority people they আপনার spondylosis হয়েছে, somebody would ascribe কানের মধ্যে ব্যালেন্সের, so something vestibular problem. But majority of these people, if you dig down the history, will have the history of headache. So naturally they can have migraine. So these are migraine associated headache. 3% of the migraineurs can present with a brief period of unconsciousness also. So don't jump on to diagnose that the migraine along with epilepsy is there. Previously, there was a term called migralepsy. And people have a tendency that I will diagnose migralepsy. Huh? So migralepsy do not exist at all nowadays. So naturally, don't jump on. In fact, people can have 3% people can have an unconsciousness. Similarly, cyclical vomiting in pediatric population can have a manifestations of migraine. So I have good two gastroenterology colleagues who have given me at least 5 kids who was having cyclical vomiting, nothing found out from their part. And just a history, if you take that, yes, their parent, one of the parent or both have the migraine. So that's a very clinical for the kids, family history of migraine. So very, very well you can document and diagnose and can treat like that way. So this could be one of the odd presentations to remember. And sometimes there is a group who can present with a hemiparesis, weakness along with a headache. That's called a familial hemiplegic migraine. This is to rarity. You would see in your practice migraine associated vertigo, unconsciousness or a dizzy spells, and cyclical vomiting, this you can have. So these are the uncommon presentations of migraine, but to remember, because these are frequently misinterpreted in other lines, other way. Then if we look into what triggers the migraine, what is the treatment? I'm not coming, but I would say majority of the triggers in India country is not a food. So majority of the triggers that we discuss in outside in Western world is food, basically. It's a packed food. Packed food contains some preservatives which stimulate the blood vessels like those. But for India, majority of the migraineurs will not have any particular food precipitant. But if you identify, you have to then prove it. Yes, if I take that food, then again it induces migraine. I have a patient who had a particularly migraine attack with spinach, palong shak khele hoy. So we have documented by giving her spinach 3 times, but it's okay. But otherwise, documentarily for India, it's a scorching sunshine, going outside, then anxiety, stress, inadequate sleep, smell, perfumes, sometimes like atorer gondo, like those. So sometimes it becomes even excessive sleep, fasting, one of the important. So these are the triggers here. So remember, we don't have to give much more dietary advice, rather to give a lifestyle advice to avoid those triggers. Now, part of the treatment, as we all know, to treat the acute attack and that to the prophylaxis. But the third, usually we avoid. That is also important. Majority of these will have a comorbid depression or a anxiety. So you have to treat that part also to have a good successful outcome in treatment of the migraine. That could be non-medicinal means like yoga, like meditations, morning walk, everything, but you have to have. And if you have a predominantly anxiety depression, then you have to treat that part also. Now, what's new in migraine management? We know all the migraine treatment and everything. Anything new, I will just look into the new one. So for acute attack, we know triptans good work well, but there is a latency if you take triptans swallowing and their onset of actions. So to offset that, we have now two options. One is a nasal spray of zolmitriptan that acts very rapidly, or else you go for a sumatriptan auto pain subcutaneous like insulin pain, and this works fantastic early. So this is the one thing, those two things are available in India, that for acute attack, if you want to abort it very rapidly, suppose a professor want to take a class, or suppose a film star want to do some outdoor shooting like those, how to deal with. So these are the things you can advise them to have a rapid relief. Prophylaxis for refractory cases who do not respond to conventional prophylactic and land up into chronic migraine, not responding very well even with a short course of a corticosteroid, or failed in 2 occasions with a short course of a corticosteroid, then you can think of injection botulinum toxin or injection erenumab is available now in India, so that you can give. So for a short course, and this is very not frequent, you have to take, so monthly injection, so you have to continue, but no doubt price is a constraint. So that thing we can think of the botulinum toxin and erenumab. So botulinum toxin we used to give. Now after erenumab, no doubt we avoid botulinum toxin because that's a painful to prick in the scalp 14 or 16 areas, and erenumab is a subcutaneous injection. It's an also auto pain, you can take it on your own. So these are the things new in migraine management for acute attack to abort rapidly, and for those with a chronic migraine or who are very refractory. Next, the second patient. This is a 25 years female in IT profession, presented with a headache, but her headache is a holocranial, dull, boring, band-like pain. Occasional nausea is there, but there is no definite photo or phonophobia. Of course, being in IT professions, she is in stress, but apparently all neurological examinations and imaging wise was normal. So what is the diagnosis? No doubt, this is a classic example of a tension type headache. So that is the one we diagnose. Now, sometimes you will have an entity, or you will see majority, somebody has written mixed headache, or mixed headache and a mixed headache, both vascular and tension type. So like those. In reality, there is a debatable thing whether the mixed headache persists or not. Because if I say there should have a very clarity, a person will have either a migraine or a tension type headache. Now look, a migraineurs of 60% of the migraineurs can have an underlying anxiety and depression. So you will, if you judge that component, then you will mix up the two and I will say that person will have a both kind of headache. Now for a tension type headache, somebody can have, as written down, occasional nausea. So like those, so you will treat things that yes, some symptoms of also migraine is there. So naturally this can be both combined entity. So look preferentially what from the beginning was there. So that is the primary diagnosis. That is not the secondary diagnosis. So that is the primary diagnosis. So I would emphasize not on the mixed headache pattern. I would emphasize that yes, find out what is the first. Now, as I say, sometimes it is difficult becomes how to differentiate between tension type and migraine. 90% is easy, they will are very different, but for 10%, they can have tension type, can have nausea, sometimes can have a photophobia even, and like those. So there are some clues that I will share. If the visual aura is there, so it's a migraine, but it's rare, I know, that visual aura in migraine. But if at all the nausea and vomiting is there, it's very minimal, number one, in tension type headache. And number two, it is a non-consistent. So you will find it out, एक दो में डॉक्टर साहब हुआ था, उसमें लग रहा था कि vomiting जैसे. And second, you will have not that prominent photophonophobia. You will not have any positive family history like that of a migraine. You will have a prominent stressor, much more in tension type headache. But the most important that I mentioned in red is that tension type headache is not worsened with physical activity. This is the quote unquote is very important. So if you had a patient with a migraine, if you ask them, when you are having your headache, do you feel that a rest is a better or you can do your activities well? They will say, no, Dr. Sir. It's rest is always a better. I go, it is not possible for me to do continue. And like those, it gives me pain. But majority of the tension type headache will continue to work like those, and that does not, the physical activity do not increase or worsen their disease status. So by this way, we can differentiate between tension type headache from the migraine. So being a clarity, mixed pattern headache, though we write it down sometimes, many of the clinicians, but their existence is questionable. There should have a particularly one, as there is a little bit overlap in symptoms with the tension type and the migraine. So that may be sometimes creating a confusion whether both coexist or like those. Next, the third one, as I say, this is again a patient, 28 years male, and he's smoker and drinks a lot, presented with a severe pain. That's a piercing pain around the right eye and the forehead that lasts for 20 to 30 minutes, along with some redness in the right eye and nasal congestions. And characteristically, it appears around 10 p.m. and is usually for the last for 30 minutes. And for last 10 days, it is appearing at the same time, no doubt. So this was the history. A young male, smoker and drinks a lot, severe pain, right periorbital with a redness of right eye, some nasal congestions, persists for around half an hour, comes at a particular time of every day, and that is coming for the last 10 days. We wanted to little dig down into the history, and then he said that I had a similar episode last year and even this time also at the same time. So what is the diagnosis? So neurological examination, as I said, for all primary headache disorder is unremarkable, and the diagnosis is a cluster headache. So this is too important to remember that clusters characteristically present at the same time of the day when it is running on that session. That session can run for weeks, 2 weeks, 3 weeks, like those, even for months, and then it will go away. And then in the next year, at the same time, it will appear. So sometimes like a cyclical. So this is also called the alarm clock headache. It's because of a circadian rhythm. So it happens like those. So this is important because clusters do not respond to conventional painkillers. So we have to identify the cluster headache very well, because they do respond to few things only. They respond to acute headache, the triptans or a high flow oxygens. For prophylaxis, we give the steroid or a verapamil, calcium channel blocker, or a lithium, you can understand. So you can understand this treatment is entirely different from that of a conventional primary headache disorders that we treat migraine and tension type headache. So it's a paramount importance to identify the cluster headache, though it is not very frequent, 1 in 1,000 possibly, it's an incidence among the headache. But we have to remember the few things that if it present like those, so that is the tension type headache is cluster headache would be like that. Next, if we look into cluster headaches belongs to a group called TAC, or the trigeminal autonomic cephalgia. I would not bore you, just to remind you that just remember that it belongs to a group where there is a name attached, trigeminal. So the pain would be in trigeminal distribution. So this gentleman had a pain in the forehead and periorbital, and they will have an autonomic symptom in the same side. So same redness of the right eye, then nasal congestion on the right side. So like those, pain on one side of the head and along with autonomic symptoms. Now there are types of different trigeminal autonomic cephalgia. Among those, the most common is a clusters, though it's rare. I said this is the most common, so I discussed. There are other types called, they are very short lasting headache called shunt, Suna, or paroxysmal hemicrania. No need to remember the names, just remember the cluster, because that is the most common among all these, which possibly you will encounter like those. So now we have almost, these patients are called primary headache, number one, and they usually present in our OPD clinic. Now we'll have a different flavor. Some patients who present not in the clinic can come, but they comes majority in the accident and emergency because of their emergent symptoms. So this is again, so these are case-based. So the learning would be rather to be interesting rather than to be boring. Again, so this is a 40 years male, hypertensive, presented with acute onset severe headache in accident and emergency. Now, the Chinmoy Junior in accident and emergency is very good, and he knows how to respond to Chinmoy and where he will ask something. So he said that there is also neck stiffness. So this gentleman who is hypertensive presented with acute onset severe headache and having a neck stiffness. So naturally, as Chinmoy trained them, now Chinmoy knows that what will be his next questions. So Chinmoy asked this gentleman in accident and emergency by phone, is the patient listless or irritable? Number one. And number two, whether he is febrile or afebrile. These two questions is very important for this gentleman, whether the person is lying listless, any movement increases the pain, or the person is just irritable, and whether the person is having a fever or not. Now, as Chinmoy trained his junior very well, who looked into the neck stiffness, naturally at the same shot, he looked into the temperature because he has to put his hand in the nape of the neck so you can understand whether temperature is there or not. So naturally, this junior has learned that whether temperature is there or not. So this junior promptly responded to Chinmoy, no sir, this person is remaining listless, not moving at all, and he is afebrile. So what is the diagnosis? Chinmoy diagnosed this condition even from a remote place that it's a subarachnoid hemorrhage because of an acute explosive headache that made to appear in the accident and emergency, where there was a neck stiffness because of a chemical meningitis, blood spilling into subarachnoid space. The person listless because any movement will increase the pain, and there was no fever, though there is some kind of a temperature can increase in subarachnoid, but majority will have an afebrile. So that is next number. So naturally, I ordered a CT scan to do and to ask this junior to send to him, and it was no doubt subarachnoid hemorrhage, and you can understand there is a blood in the sylvian cistern and as well as the suprasellar cistern. So we did a angio and there was aneurysm, a big. So naturally, in my diagnosed with the help of the juniors, even in accident and emergency, this person having a subarachnoid hemorrhage. Now, this gentleman on the next day, similar kind of patient came, and this junior responded to Chinmoy, they said, this is just the opposite. The person is very irritable and he is febrile. Then what is your diagnosis? It's a meningoencephalitis. You ordered an MRI with a contrast scan so that to look into whether there is any contrast enhancement in the meninges. You got it. You did CSF and routine and everything. I'm not going into. I'm just coming into how to think and how to diagnose the things. So Chinmoy and Junior diagnosed these two diseases very well in emergency by having just two clues. So like those. Next, another patient. So this is a patient that came in the accident and emergency. So this patient presented with something, a holocranial headache, slowness and slow response for the last 5 days. And there was a history of trivial trauma. So you can understand that this person presented in the emergency that he developed of all these headache manifestations after a trivial trauma, and then basically he had headache, and family noticed that he is becoming a slow, and response also became slow. And this is a 65 years male, and he had a history of hypertension and ischemic heart disease. So naturally, again, the Chinmoy Junior called Chinmoy. What to do, sir? This patient has come to. Chinmoy said, I need a clinical examinations. Please do the clinical examinations and let me know what is there. The junior is very prompt. He did all the examinations and say, no, sir, clinically there is no focal neurodeficits. So focal neurodeficits means weakness on one side of the body. So sometimes you have a lateral rectus palsy indicating raised intracranial tensions, something, anything focal in the body. So there is a no focal neurodeficit, no neck stiffness. And this junior was so good that he did a ophthalmoscopy also, and the fundus was normal. So there was no sign of raised intracranial tension. Then no doubt, so this is an elderly gentleman who had a history of hypertension, had a ischemic heart disease. That gives a clue to you that possibly the person is on some kinds of a blood thinners. So Chinmoy again asked the junior whether he is on any blood thinner. The junior responded, yes, sir. He is on clopidogrel 75 milligram for ischemic heart disease. And at a trivial trauma, what do you expect? Who are on a blood thinner? So naturally, Chinmoy ordered a CT scan, and that was like this. It was a subdural hematoma, which is very common sometimes from elderly with a trivial trauma, particularly on some drugs which are a blood thinners. So you can understand with CT, there are a subdural hematoma on the both sides, and it's an acute and chronic hematoma that might sometimes require urgent barhole evacuations, and that gives a fantastic outcome. So naturally, this gives an everything clue. Now, as Chinmoy instructed this gentleman in the emergency to look for a clinical examination, the same set patient came in another day, and this gentleman again called the Chinmoy and said that, yes, sir, this time the person is having a right hemiparesis, but it's not very profound weakness, but I would say, sir, it's almost power of a 4/5. So mild weakness on the right side. So presented with a headache, right-sided weakness, mild, elderly, with on clopidogrel, developed over 7 days. So response is slow. So again, Chinmoy ordered, yes, Chinmoy has a back in the mind. I got the answer, do a CT scan. So naturally, Chinmoy was expecting to have some extradural hematoma. So extradural hematoma will have a focal deficits because of a compressions on one side. So here in screen, you can see there is a left-sided compression. So this patient presented with a little right hemiparesis, or the person can have an intracerebral hemorrhage like those, and when it dissects out into the ventricle, the persons will have a profound headache and little right-sided weakness. So this is a classic example of patient who come to the accident and emergency and can present with, and Chinmoy and team can diagnose very well like this. Next, again, another set of patient. So before that, I would say the headache with focal neurodeficit, if you get it, like hemiparesis, monoparesis, or there is a ptosis, or there is a diplopia, like those things. So you know that you are dealing with something where you are expecting a structural lesions in the brain. So remember for headache with focal neurodeficit, like stroke, like extradural hematoma, there can you have a cerebral abscess or can have a cerebral tumor also. I'm showing you one MRI of our patients that has a multiple abscess like this. He presented young male severe headache, so like this, and initially it gave us an impressions of an tubercular abscess like present like this, but naturally he did not respond it to very well, and he was going down. We had to force to do one biopsy to underlying disease to know the underlying disease, and this way reported, and it came out to be a CNS melioidosis. So basically, any infections, abscess can sometimes present with a focal neurodeficit like those to remember. Next, again, this set of patients. So another set of patients you have to remember. This is basically a 30 years female. Remember, this lady is obese, hypothyroid, and she presented with a headache, which is a holocranial, dull aching for last 1 month, and along with a blurring of vision and 2 episodes of transient blindness. So I will just split. Number 1, remember 30 years, so young female, obese, presented with a holocranial headache, blurring of vision, one important. So that gives an, I said a red flag, blurring of vision is there. So there is a red flag, blurring of vision. And 2 episodes of transient obscurations of visions or amaurosis fugax or a transient blindness. So possibly we are dealing with a secondary headache. There is a one red flag, visual obscurations, another red flag, blurring of the visions. So naturally, possibly we are dealing with a secondary headache. So one clue, young female, obese. So then Chinmoy wanted that one should have a clinical examinations, And this lady has a bilateral lateral rectus palsy, and she had florid papilledema. Then what is the diagnosis? Chinmoy ordered the MRI should be done, and the MRI revealed that the optic nerve, if you look into, so they have tortuous, there is prominent perioptic CSF if you look, and there is a empty sella turcica. So you have three things in the MRI. Chinmoy promptly diagnosed the conditions. It's a idiopathic intracranial hypertension, IIH. So idiopathic intracranial hypertension usually happens in young females, are much more common than the male. So if you remember this clinical history, it's absolutely for a particular patient. And you can have a history of hypothyroid, for obesity or anything like those. They present with a headache, initially subtle, goes on, until the visual obscurations because of a raised intracranial tension. She had visual obscurations and a threat to the visions. So they had to be treated very promptly to reduce the intracranial pressure. There are ways of treating like those. I'm not coming to these things, but just to have a flavor of presentations that come to be like this. Next, again, another patient, same patient, 30 years female. This lady, again, not presented in that previous way, but a different way. Again, she presented with a severe postural headache. But this is relieved by lying down for last 10 days. There is no history of trauma or anything. The lady presented with a severe headache whenever she adopts an erect posture. Means whether she is sitting or standing, there is a headache, and lie down, there is no headache, like this. So naturally, then neurological examination was done for the previous patient. It was absolutely normal. Now the Chinmoy ordered for an MRI to look into. Why? Because this is a postural headache. So possibly some kind of a secondary headache disorder we are dealing. Because as we know, the red flag, is a posture changes headache or like those. So naturally, Chinmoy ordered an MRI. It's a plain MRI. What you can see, very interesting. You are seeing the whole meninges, whole meninges you are seeing. But it's a non-contrast. So it's a non-contrast MRI. In contrast, you can see meninges during meningitis. But so prominent meninges, but in a non-contrast can be seen in a condition, or you can see even there is a subdural effusion, both the side. Small subdural effusion along with a meninges, as if the meninges you are seeing like something drawing and like those. So this is the condition called spontaneous intracranial hypotension. So the last patient was hypertension intracranial, and this patient is intracranial hypotension. So whenever she adopts an erect posture, brain sags, meninges gets something traction is there. So they will have an intractable pain. When lie down, brain do not sag, meninges do not have a traction, they will not have a pain. So this is very important clue to diagnose spontaneous intracranial hypotension, whether it's a very postural headache. You know, this kind of headache, everybody you have seen after lumbar puncture. After lumbar puncture, few CSF comes out, patient complain of headache next day. So that's because of a hypotension, you know. But if it is a non-traumatic, not done anything, then spontaneously it can happen. The treatment I'm not coming, it's a blood patch has to be given. So like those, as I said, to have the different flavor. Next, again, another patient, as I said, I have split to the 30 years female. So naturally, again, a 30 years female presented with subacute onset, severe holocranial headache, 1 episode of seizure, that was a focal seizure followed by secondary generalization and drowsiness. Now, again, we have a red flag. What is that? Seizure. So we said, if there is a drowsiness, if there is a seizure, if there is a visual phenomena, then you look for a secondary cause. So here again, the secondary, first one secondary, we have a clue, second one secondary, we have a clue, third one. So again, we are going like that, just to remember that chart. So severe headache, then 1 episode of seizure, focal with secondary generalization, and drowsiness. 30 years female, like those. So Chinmoy Jr. again did down the history very well in the emergency, and he informed Chinmoy that this lady has a history of OCP, oral contraceptive pill use, for the last 3 years. This is a very important clue if someone presented with a headache, with seizures, drowsiness, and having a history of a contraceptive pill use or a hormonal medication use. Naturally, Chinmoy asked this junior to examine the eyes whether there is any raised intracranial pressure, and this junior had a good photograph. He sent it to Chinmoy. There was florid papilledema. So naturally, Chinmoy ordered MRI to be done, and MRI was done, and that was showing along with there are the superior sagittal sinus was not clearly visible, and for that things all other tributaries draining that area is become more prominent. So this is a classic case of superior sagittal sinus thrombosis. So dural venous sinus thrombosis can happen, but it is much common in persons particularly who are prone. The proneness is with medication, proneness with some other forms who have a congenital narrow transverse sinus stenosis. Proneness can be with some connective tissue disease and like those. So we have to remember. So female populations are much more presented with headache, rest ICT, and a focal seizures or something can have superior sagittal sinus thrombosis. Because if we miss it, the treatment remains with a something called anticoagulation. Even this person had a hemorrhage in the brain, you have to give because of a venous back pressure, you have to give anticoagulation promptly on the very first day. And they're very much treatable. A comatose patient wakes up on the 2 days and like those. So this is one of the important in accident and emergency to diagnose. Again, TS female that presented with a acute onset severe headache, blurring of vision 6 hours postpartum. Do you have any red flag? Yes, I said pregnancy and postpartum headache. That's a red flag number 1. Number 2, blurring of vision. So we have 2 red flag in this lady. One is a 6 hours postpartum and another is a blurring of the visions. So we know possibly we are dealing with a secondary headache. So naturally, in my order, yes, like for the last patients, you do the examinations, and this junior was excellent, did a fundoscopy, and it was normal, not like that of the other patients, like the previous one who had a raised ICT. Then what to do? Then Chinmoy ordered, yes, do an MRI then, see, as it is a secondary headache, imaging should be done. So Chinmoy ordered an MRI, MRI was done. So MRI clearly shows there are some form of hyper intensity in flare sequence, and particularly in the occipital region, both the sides. So what is the diagnosis? Classic case, postpartum headache, first time developing, acute onset, normal fundoscopy, and with imaging evidence of hyperintensity long tear in the posterior part of the brain. It's called posterior reversible encephalopathy syndrome, or a PRESS syndrome we commonly see. So PRESS syndrome is important to diagnose because it's a reversible, the name itself, reversible encephalopathy syndrome. So you can assure the patient your blurring of vision because of occipital edema will go, and you will have your vision after 2 weeks or like those. So you will be all right, and the patients will treat you like a god because you forecasted the thing beforehand that you will have your visions and everything. So this is because of a sudden surge of blood pressure in the postpartum period that leads to leakage of the blood vessels, leading to edema, which are more vulnerable area is the posterior part. But I must say, this edema can happen to any other part of the brain also. So I would say maybe the name PRESS, P is a misnomer. It should be reversible encephalopathy syndrome. Posterior is the most common, but it can happen to temporal lobe also, amnestic presentation. Next, I have diagnosed many. Next again, another one. So again, 30-year pregnant lady. She presented with a sudden severe headache and blindness. So any red flag? Yes, again, number 1, pregnancy. So last one was postpartum. I said in the red flag sign, pregnancy, postpartum is a red flag. Number 2, blindness. I said any blindness, visual problems, or seizure, or mentation changes is a red flag. So here, this lady also presented with a 2 red flag in the accident and emergency. So naturally, Chinmoy Jr. is a master one right now. So he knows that yes, there is a 2 red flag, what I have to do. So he did the clinical examinations, and now he informed Chinmoy that this lady, along with this history presented, had ophthalmoplegia. Ophthalmoplegia means the eyes are not moving very well on either of the directions. So like those. So it's ophthalmoplegia is there. Okay. So then Chinmoy said, of course, it's a secondary headache. We will go for an imaging. So Chinmoy did an imaging. So if you look carefully, you will see in pituitary area, there is a black area followed by surrounding white area. So what is these conditions? Like if you see, there is a pituitary, above there is a optic chiasma, and below the chiasma there is a hyperintensity. If you are looking into, so basically this is diagnosis is pituitary apoplexy. So this is very emergency. So any pregnant patient, particularly who have a pituitary adenoma, even without pituitary adenoma, not knowingly, they can have apoplexy, and that can present with a severe headache, blindness. And just a clue, pregnancy, severe headache, blindness, and ophthalmoplegia, possibly we are dealing with a pituitary apoplexy. Why blindness? Because the chiasma is here. Chiasma get compressed, so you are blind because the both fibers crosses there. And why ophthalmoplegia? Because the nerves are going, third nerve and the sixth nerve, so they get stretched. So you have ophthalmoplegia. So this is again the Chinmoy Junior diagnosed, referred properly, and urgent intervention done and recovered. Next again, I will come to another. This is little bit elderly lady. We have finished the young ones, so we have gone to the elderly. 65 years female, presented with a severe headache in right temporal area. I told you the locations of the headache is also important. So this is right temporal area for last 1 month, that not responded to conventional painkillers. She went to many persons, but this is not responded. She had the history of jaw claudications also. Jaw claudication means fatigue in the whenever you are chewing for a prolonged period of the time. And there was a recent decreased vision in the right eye for the last 7 days. So any red flag? Yes. Number one, age more than 50. So 65 is this lady. Number two is decrease in the vision in the right eye. So we have 2 red flag again from that list of red flag. So naturally, possibly we are dealing with a secondary headache that we have to look into. So naturally, Chinmoy explored as being a pain specialist, whether this lady had pain in other areas or also not. So that lady responded, yes, doc, I had a pain in the neck, shoulder, hip for the last 6 months. And you know, this is very annoying. People used to call me, you have a functional pain and like those. But I was having this until I developed these things. They were not giving me importance and all those things. So Chinmoy look for a scalp tenderness in the temporal area. So he got the scalp tenderness. Chinmoy ordered for an ESR. This was very high. ESR, hemoglobin was normal. And now Chinmoy ordered to do an high resolution ultrasonography of the temporal artery to look into. And Chinmoy got this. This is called halo sign. You see surrounding black over the red artery. So this is called a halo. Means the artery gets thickened. Thickened artery gets in transverse sections is a halo. So this is called a halo sign. So naturally diagnosis is a temporal or giant cell arteritis. Previously we used to do biopsies. Now biopsy is not mandatory because there are difficulty in doing temporal artery biopsy. People are not easily accepting the things and like those. So even nowadays the HRUSG can tell you if there is a halo sign and if you have all other features matching with these features of your temporal arteritis, so they matches well with a temporal arteritis. So this is a temporal arteritis or giant cell arteritis. So can you explain her pain in the neck, shoulder and hip for last 6 months? It is basically polymyalgia rheumatica. So polymyalgia rheumatica patients will have a more chance of having giant cell arteritis. So for temporal arteritis, almost 60% will have a polymyalgia rheumatica. So you have to have this history, which majority of goes like a functional weakness. So this is a large series that we have presented in rheumatology, because the treatment of temporal arteritis is entirely different. It's with a corticosteroid. They do not respond with any other medicines, whatever you will give. So this lady do not respond to any painkillers. That's a natural. So we have a good series. But the problem is that how long you will give corticosteroid, because the flares, whenever the corticosteroid is being tapped down to around 10-15 milligram. So this is a study we looked into to have another agent so that we can spare the steroid. And we published it. So now we use leflunomide as a steroid sparing agent for giant cell arteritis. There are another agents which you can use. That's a MUMAB antibody, but no doubt that's a very costly. So naturally, this is one sparing agent that has been accepted, and naturally you can use as a sparing of a giant cell arteritis. Next, again, possibly I'm coming through the end of 2 or 3 slides. This is again a 60 years old female. having history of migraine. So 60 history of migraine without aura, and naturally recently prescribed topiramate for his disabling migraine headache. Now on accident and emergency, she came with a sudden severe pain, eye pain, vomiting, and worsening of vision. So just listen, this is very interesting history. And this is not, I have right down to say patients, whatever I have showed you, this is patients that we do see day by day. So this is 60 years elderly female who had a migraine. And for this disabling migraine, she was given topiramate, which works very well for the migraine, no doubt. But after starting topiramate, she presented in the emergency, remember, not in the clinic. She came to the emergency with a sudden severe headache, eye pain, vomiting, worsening of vision. Again, the Chinmoy Jr. found out whether that there is a red flag. Yes, age 60, number one. Though she had history of migraine, a new pattern of headache, sudden severe, explosive onset. So naturally, second clue. Third, worsening of vision. So naturally, there are 3 red flags among this lady. So naturally, Chinmoy no doubt wanted to say, is there any neurodeficit? So naturally, then Chinmoy Jr. said that there is a no neurodeficit. Can you know what is these things? This is basically acute angle closure glaucoma because of topiramate. So topiramate is a drug which can cause an acute angle closure glaucoma. So topiramate, whenever you are prescribing to someone for pain, migraine, and anything, please write down, if you have a pain in the eye or a worsening vision, please stop and come to me. Otherwise, maybe in a court of law, it can be sued like those. So topiramate is a fantastic molecule to treat migraine. But remember, few persons, there are few country who advocate to look for a narrow angle, whether is there before prescribing topiramate. But usually it is not advocated because it's an idiosyncratic reactions, but no doubt they developed in a persons with an angle closure. So, but likely, so naturally remember that whenever you are prescribing topiramate, this one thing, I have faced these things in, because of one of my colleague prescribed topiramate. So I don't know whether Chinmoy was here possibly at that time. That lady developed like these things, and they wanted to come to me to know whether this is drug induced, everything like those. Then I had to explain the whole thing, how it happens like those. So there is nothing wrong in prescribing topiramate. I myself prescribe topiramate also a lot, but the thing is you should write it down. That will take away all those things. But you have to know that this thing can happen with a topiramate, or before prescribing, ask the persons whether you have a history of a something glaucoma or history of a renal stone before prescribing topiramate. These 2 things has to be remembered. So that is the one. Again, possibly this is the series we are discussing with last 40 years old female, well controlled, hypertensive, presented in accident and emergency with 1 episodes of epileptic seizure. She had history of chronic headache and 4 episodes of transient focal neurodeficit that corrected spontaneously within an hour in the preceding 6 months. So Chinmoy Jr. is very fantastic. He took all the history. Number one, this lady, young, 40 years, well-controlled, hypertensive, though, but he presented with a epileptic seizure. So red flag, one is headache, hypertensive, epileptic seizure. So naturally, though chronic headache persisting, but this gentleman has 2 clues. One is a seizure that with she presented, number one. And second, she had transient focal neurodeficit that corrected spontaneously within an hour. So this is called transient ischemic attack, or TIA. TIA, small stroke, minor stroke, whatever, just a mini stroke, like those. And that corrected within the preceding 6 months. So we had a clue, it's a secondary headache. Along with the headache, there is a seizure. There is a TIA. So possibly we are dealing with a vessel disorders. Na? Small vessels occluded, we have TIA, small vessel occluded, small stroke cortically, that stimulates to generate the seizures and like those. So naturally, Chinmoy concluded in a way, a patient presented with a headache, along with a TIA, along with a seizure. So naturally, Chinmoy was very serious and no, admit the patient, and no doubt the diagnosis seems to be as a CNS vasculitis. This is again a series of patients we have presented a headache with CNS vasculitis, primary CNS vasculitis, because to find out another drug, steroid sparing, which we can use. So we have used mycophenolate mofetil, well accepted. Now it is recommended, mycophenolate mofetil in treatment of steroid. You can see we have presented you with very nice narrowing of artery in DSA, which remain opened after treatment with a mycophenolate. So something you have to immune suppression to be used. So these were a host of clinical cases that I showed to you, starting from how they come with a subarachnoid hemorrhage. Then along with that subarachnoid, you can have a meningitis. So you just flip-flop, person is a listless or irritable, flip-flop, febrile or afebrile. Next, the person with a headache with a focal deficit can have a extradural hematoma, can have an abscess, can have a tumor. Without focal neurodeficits, along with a headache in an elderly with a trivial trauma, think of a subdural hemorrhage, which are very treatable. Then we have a host of the females, 30 years, who presented with a raised intracranial tensions, which we have saw that it could be naturally idiopathic intracranial hypertension. When we have a postural, better with a lying, it can be intracranial spontaneous hypotension. We saw that with a intracranial hypertension, we can have a CVT, particularly use of a your oral contraceptive pill. Postpartum period, you remember the PRES. Pregnancy period, naturally you remember the pituitary apoplexy. And then again, in a particular site pain, like a temporal area, along with a vision problem, that's a temporal arteritis. And along with a headache, seizures, and along with a TI-like presentation can be vasculitis. So these are the host of clinical cases from my archive I presented you to show. So in conclusion, I would say headache is a very common neurological symptom as like of a fever or anything else, but it can be a manifestation of a very benign as well as a severe underlying life-threatening disease. So look like that way to identify, to dig out those devastating disease so that which you can evaluate very well. Appropriate evaluation leads to successful outcome. Thank you and Shubho Sharodia.
Very nice and very detailed presentation. I hope that those who are present, they will get tremendous benefit from this presentation. As a pain physician, actually we are mainly interested to treat the primary headaches. But then if we cannot rule out the secondary, then how will we remain safe? So how, all these entities, if we know, then only we can rule out, then only our mind doesn't know, eyes don't see. Exactly. So eyes has to see every time. I cannot say that, okay, I am seeing headache patient, but not you. I cannot say like that. So every headache patient, what it can be, we should have an idea. First things. Okay, is there any question? I ask the participants, you can unmute and ask a question. If there is any question. Nobody has written any question in the chat, so okay.
Good evening, sir.
Yes, Dr. Senthil.
Sir, what is the role of sumatriptan nasal administration? Is it preferred over oral administration during aura phase in migraine?
Exactly. Good questions. So as I said, for any triptans you are using orally, it takes around 15 minutes to 30 minutes to act actually. So naturally those period, the person is suffering pain and like those. So to bypass the things, the gastric and everything, so we have two things in hand. One is you can have a intranasal spray. And nowadays, we can have your injections, subcutaneous injections. So among the nasal spray, zolmitriptan nasal spray is available, and that is a much more faster onset of action. Not during aura phase, at the beginning of the headache, if you have it, you can have a nasal spray, so it can be, or you can have nowadays, I think in the last month, it was launched a auto pen for sumatriptan, so that you can take. And they have a very rapid onset of action. So nasal would have, I think, 5 to 10 minutes. I'm not very sure of exact minute, but it would be between 5 and 10 minutes. And for subcut, it is 3 to 7 minutes or just like those. So these things is very important. That you are right, they can be used. That is to bypass your gastric route.
Thank you, sir.
Okay, one person, Dr. Reena Mittal she has asked, how long topiramate should be prescribed? Is there any alternative to topiramate for migraine?
Yes, number one, you have a host of prophylaxis for migraine. So starting from a beta blocker, propranolol, to some anti-seizure medications also, like topiramate, like valproate, next gabapentin even you can use. Then you have some tricyclic antidepressant like amitriptyline or nortriptyline you can use. Even desvenlafaxine you can use. So there are a host of the prophylaxis, flunarizine, calcium channel blocker you can use. So there is a host of the things which you can use. The beauty of the things is why there are different medications is that now for a particular patients, you have to choose one, but that would depend upon other comorbidities. Like I said, for me, one person came, young female, so she is very obese. And then she had headache, which was diagnosed to be migraine. Now, what prophylaxis I would choose? I would prefer to be topiramate because I wanted to, at the same time, she would lose weight sometimes. So I would not choose something which will gain weight. Similarly, think of a young male. He came with a severe headache. So for a prophylaxis, which one you would choose? I would not choose beta blocker because that can lead to erectile dysfunctions. So I would choose for him maybe a valproate, maybe another flunarizine, just like those. But for that lady, I would not choose valproate because that will increase the weight. I would not choose flunarizine, that will increase the weight. I would not choose amitriptyline. So look, the chain things depends upon. That lady had not a obese, but had a PCOD. You would not choose valproate, again, polycystic ovary. You would choose something different. Lady had that anxiety. So naturally, you would choose something like a amitriptyline, nortriptyline, or a desvenlafaxine, like those. So one thing is, there is nothing called topiramate you can give for a long period of the time. There is no harm on it because for epilepsy, we use topiramate, which sometimes went on for years after years. But the thing is that you have to be cautious because this reaction is an idiosyncratic. So it can happen even with a low dose, though we start with a 25 milligram once daily doses, but even it can happen with a 25 to 50 milligram doses because of idiosyncrasy. Number one. So you have to be cautious whenever you are starting, number one. And for migraine prophylaxis, what I principally follow, I tell them a guideline that yes, you would be on medication for 6 to 9 months. Afterwards, I'm going to stop your prophylaxis maybe. But before that, adopt a good things that you will avoid all the triggers. So find out your trigger, have good amount of yoga meditation, have plenty of the water, remove your anxiety, do some good work like those. And naturally, majority, I would say around 60 to 80% will have a success rate. No doubt there is a failure. Person will have the same thing, relapse and everything. So for topiramate, for migraine prophylaxis, as long as you are satisfied that topiramate is working, you can use it. So maybe 9 months, 6-9 months, 1 year. And if your topiramate is working well, and if you need the drugs, you can use for 1.5 years also. So nothing like this. Chinmoy, there are some other questions also. No? One is monitoring for glaucoma in topiramate drug by Dr. Saroj Mina. Very good, fantastic question. I would say if you have an access of an ophthalmologist, then ask him or her whether there is a person is having a narrow angle or not. So that is the one thing you can do. If they're not narrow angle, then the chance of having acute angle closure glaucoma is far less. Then can use. But if the person is on topiramate and if does not complain of any eye pain or partial vision problem, there is no recommendation that you should look for your narrow angle glaucoma or something like those. Because what happens is actually because of an edema, the angle gets, because of idiosyncratic reaction, angle gets closed. It's not like that for a narrow angle. Why happens to acute angle closure glaucoma? It's because of a narrow angle. Why the narrow angle? Then what happens if you give a drug which will dilate the pupil, they will have a closed angle. So it happens with amitriptyline that dilates the eye. It happens with SSRI that dilates the eye, like we are using commonly SSRI, that also happens. So similarly, any eye drug that will also dilate can have an acute angle closure. But the mechanism of doing acute angle closure glaucoma by topiramate is something different. So they causes actually because of an idiosyncratic reactions, some edema, swelling in ciliary like those, and the angle gets blocked. So if you don't have idiosyncratic, you will possibly not have those things. One thing is only before giving, you can have a whether this is a acute narrow angle is there. There is a no need after giving, people are well, no need to check for a glaucoma or just like those. If you can person complain for an eye pain or vision problem, then only you can check. Then again, the symptoms are periodic before appearance of symptom. Now, as I said, if you are giving topiramate, if you have a good colleague, you can check it out whether there is a narrow angle. If narrow angle, you can avoid. If there is a no narrow angle, you can give it. If you have no access, you are giving the drug, just have an open eye. You just ask for the symptoms next visit, or ask the patients if anything has developed to bring your notice. Otherwise, nothing more. Next, cost of sumatriptan and brand name. Brand name, there are many things. I think brand name, I would not say for a particular brand. And if you look for a sumatriptan tablets, I think it's between 25 to 40 rupees, like those. For injection, it's a costly right now. It's available by one brand only. So that's a costly, I think close to, I'm not exactly, may not be right, 800 to 900 rupees for each auto pain and like those, for each dose, like those. For Zolmitriptan nasal spray is available. It's you can have a 6 to 8 spray, 8 to 10 spray, which can have in range of 500, I think. But for drugs and this price, I would be very truthful to you. These price and things, I'm not remembering very well. So I may be wrong, but I'm giving you a good guess idea like those. But exactly, the clinical content I can say, but the drug name I'm not using. You can Google it out, but this should not be done by us. So any other? Sir, role of biofeedback in chronic headache. Fantastic question. Anyone using biofeedback therapy in your practice? Yes. Number one, for chronic migraine, I said that in migraine, there are 3 treatment arms. One is acute attack, one is a prophylaxis, and others which we don't look into. That is non-drug. Non-drug is look into depression, look into anxiety, have the yoga, meditation, all the things. Similarly, there are other way which you can do. That's called biofeedback. So there is a biofeedback by which you can reduce the migraine also. I would say you recently a device has been available in the market. So I would not say their name because it's available. It's the name of a native. I'm telling you. So there is like a band. You have to put it here. So that band will stimulate some signals that you can monitor from your smartphone. They will give you an app and how much stimulus you will give. So by these things, you monitoring, you will stimulate your brain areas through biofeedback, and that way it reduces migraine. And this is I'm not talking about a few devices which are available OTC or maybe in something like that, but I'm talking about this device is US FDA approved. So you can understand this is a device which has been approved by US FDA for biofeedback and for treatment of a migraine, both episodics, but the episodes are much more, or a chronic migraine. You can use it without devoid of a side effects. So that is available like those. And there are other way of biofeedback also. There is like occipital nerve you can stimulate in cervicogenic headache, in for few other neurology from headache. Those biofeedbacks, few are available here. But one of the important thing is a biofeedback by that, I told you by that instrument is good, but again, the cost is a bar. So for that instrument to stimulate for 3 months, I think that takes around, exactly, they will give you some discount also, but it could be close to 15,000 rupees. So you can understand 15,000 rupees in 3 months. So naturally is a big one, but they are coming. And I have a hope once their patent goes, everybody will jump on to have these things. Is there a role of short course of steroid for chronic migraine before starting prophylactic drug? That was given by Dr. Karan Ramaswamy. Very fantastic. So I told you, that is, I showed that slide, what you diagnose. It's a migraine, or it's a chronic migraine, or it's a medication overuse headache, because the treatment changes. For chronic disabling migraine, we use a short course of steroids so that people do not use the painkillers, will not land up into medication overuse headache. And this is for 10 to 14-day course until your prophylaxis agents goes on working. So you are absolutely right. You can use a short course of steroid during chronic migraine. And you know how it works? Because migraine is a neuroinflammation. So you are giving a steroid to suppress the inflammations and going back to the episodic nature of the disease. That's a fantastic question. think Chinmoy, we have finished the questions that was written. Anything?
Yes. So no, I think we have discussed a lot of time. So I thank you again for taking out your precious time. As we know, you are a very busy practitioner. So thank you again. Thank you again, and we will like to have you again in future webinars. Okay then.
Thank you, Chinmoy. I must thanks all the listeners and you who stick to here for long period of time. Anytime, if you want to interact, I am open. Nothing. My number is with Chinmoy available. Just send me on WhatsApp. So no issues. Even for some things we can discuss if you feel so like those. I am thankful that you are stuck to all the things alike. And thank you, Chinmoy, being my good friend and colleague and always supportive. So Chinmoy, thank you. Thank you.
Okay, thanks.
Shubho Sharodiya. Namaskar.
Shubho Sharodiya. Okay, thank you.